Good evening, everyone. I'm Dr. Vinisha, and today we'll be discussing about the preoperative assessment and preparation of the pediatric patient for surgery. So, what are the goals of doing a PAC in a child? Like, why do you have to see it differently from what you see it as an adult? So, main thing is to identify the medical issue for which the child has come. Okay. See the current status of health of the child, like whether the child is fit to undergo anesthesia, optimize any comorbid conditions, if any, and communication. It is very important to educate the parent, like about the surgical procedure, about anesthesia, and what they should expect perioperatively. Also, when you meet the child, you have to develop a rapport with the child because the child is always more comfortable with a familiar face in the operating room. And lastly, you have to ensure high quality perioperative care. So what happens is most often the surgical procedure which the child comes for is small. So parents are more concerned about the risk of anesthesia. So always remember, it is as much about comfort as it is about the safety of the child. So now regarding the psychological aspect of the child, like you have to solve the concerns and anxiety regarding anesthesia. You have to discuss the available options, what the parent and the child should expect perioperatively. You give them instructions like the preoperative fasting guidelines and any other instructions you have to give them prior. So what is the main issue? Why is the child anxious? So the child can have fear about the pain, the needles, injections, dying, not waking up. And the main thing is separation from their parents. Okay. So what are the risk factors for anxiety in children? So age is the most important risk factor. Like anxiety starts developing at approximately 7 to 8 months of age and usually peaks at about 1 year. Children less than 7 months do not usually need pre-medication and they easily accept surrogate parents. So we'll discuss this further in the pre-medication bit. Children with emotional temperaments, they are more likely to develop anxiety. Those who've had like repeated medical procedures and they've had a negative experience prior, repeated hospitalizations, and an anxious parent. Okay. So now we'll begin with history. Every PAC begins with history. We will discuss the points which are specific in the pediatric population. So you firstly begin with reviewing of your medical records. Often the child is already worked up and has records from like routine visits with the pediatrician. So you look at the current history and the past history. Then you look at the present illness, like the main complaint which has brought the child to the hospital. Now, the medical history, if the child has any comorbidities, like very rarely the child presents with like your blood pressure, diabetes, and stuff like that. The more common illnesses in children are like neurocognitive dysfunctions, they have seizures, they have syndromes, asthma, congenital disorders. So, that is what you look for in a child. So, basically, you look for any condition which can increase the risk of perioperative complications. You review the medicines that the child is taking. If the child is on any anticonvulsants, they're on long-term steroid therapy. Those who are asthmatic may be taking some MDIs. So you review those. Then you ask about the birth history. This is what is like mainly different from adults. So if the child was born premature or was the child full term, you ask how the neonatal course was, whether the child required any ventilation, was the child in the ICU. We'll discuss in this further why it's important. Then you also ask for the immunization history. So there, like vaccination can be followed by like fever, rashes, headache, and malaise. So there is not enough clear evidence like what are the anesthesia implications of immunization. But then it's recommended to avoid elective surgery at least 3 days after inactivated toxins vaccines and 2 weeks after live attenuated organism vaccines. You review your major organ systems, your CNS, CBS, RS, and per abdomen. So the important thing is just while taking the history from the parents, when you're observing the child from the distance, also you can gather a lot of information, like whether the child is active, whether he's playing, are there any developmental problems, is the child wheezing, is the child interacting properly. So that can also give you valuable information. So you see if the child has any previous anesthesia records, this can be very helpful. Like you'll get information regarding the airway, like the vascular access, medications, or any complications. So in this aspect, even the parents will give you valuable information, like if the child had any delayed emergence, whether they had difficulty in getting an IV line for the child. And like from pre-medication, they can even tell you like what worked well, or more importantly, what did not work well for the child. Allergic history, this also should be noted so that you can so to avoid unintentional exposure to the allergic medication, if any. So the important thing in children, especially in neonates, is latex allergy. Those patients who come with meningomyelocele and those who've undergone multiple surgeries, they can have latex allergy. So it's very important to look for this in younger children. The other thing you look for is family history, especially in another sibling and the parents. Like if there is any history of malignant hypothermia, the sibling has any muscular disorders like muscle dystrophies, prolonged paralysis. This can be because of pseudocholinesterase deficiency, any bleeding tendencies, and any post-operative nausea, vomiting if another sibling or parent had that. Now, regarding post-operative vomiting in the children, there are risk factors. There are 4 important risk factors, and each risk factor is given 1 point. So, when the duration of surgery is more than 30 minutes, when the age of the child is more than 3 years, any eye surgery, especially strabismus surgery, and history of POV in sibling or parent. So, as you can see in this graph, the risk of post-operative vomiting increases in proportion to the number of risk factors in children. So you need to identify these risk factors in history so that you can accordingly administer more dual antiemetics or triple antiemetics if need be. So now we always find out like whether the child was born full term or preterm. So why do we always ask this? So when the child is premature, born not full term, the risk factor for apnea of prematurity, bronchopulmonary dysplasia, intraventricular hemorrhage, which can be associated with hydrocephalus, the child can even have a VP shunt, the risk of hypoglycemia and subglottic stenosis is increased in premature kids. So now we'll discuss one system. We'll start with the main system, that's the respiratory system. So respiratory system is the main contributor of complications in pediatric patients. Like children always have a higher chance of like airway collapse, they have a lesser reserve, they desaturate faster, develop hypoxia, and they also have a predominantly parasympathetic tone. So they can easily go into laryngospasm and apnea even with like just your secretions during intubation or during suction. So the respiratory system problems which you look at while assessing the child will be if the child has a reactive airway, or upper respiratory tract infection, if the child has any asthma, passive smoking in the parent, obstructive sleep apnea, and bronchopulmonary dysplasia. So we'll discuss the apnea of prematurity first. So what is apnea of prematurity? Like it's cessation of breathing, which is either like 15 seconds or of a shorter duration when it's associated with either bradycardia. Now, bradycardia in children is even with a heart rate less than 100, cyanosis, or pallor. Now, several studies have described an increase in incidence of apnea in premature infants. Now, probability of apnea is inversely related to the post-conceptual age. So if the child already has episodes of apnea at home or the child is anemic, this increases the likelihood of developing apnea post-operatively. So this risk persists till at least 44 weeks post-conceptual age, after which the risk for apnea declines. So even when you're doing a minor procedure in a younger child, like just they come for a herniorrhaphy, it is not suitable to do them under daycare procedures. It's always better to have them admitted and observe them overnight for apnea. The other common illness in children is asthma. So with asthma, there's a risk of perioperative respiratory complication. Like it can persist to be high for many weeks after an acute episode. There's an increase in risk of intraoperative and postoperative bronchospasm and laryngospasm. So when you have an asthmatic child, what you should assess in the history is you see the degree of control of asthma and you try and optimize the patient for surgery. So you'll see that the asthmatic is poorly controlled when they have daily symptoms. They're using like short-acting beta agonist therapy. They have weekly nighttime awakenings, and they're on long-term oral steroids for exacerbations. On auscultation, you see if the child has like an expiratory wheeze. If there is active wheeze, the elective surgery may need to be postponed. You can ask for a recent chest x-ray to be reviewed in the investigations. And for optimization, you can give them like nebulization just prior to shifting them to the OT, a shot of steroids if needed, and anticholinergics to reduce your secretions and stimulation of the airway. Now, upper respiratory tract infection. Now, this is a very common occurrence in children. The complications which can occur because of it are like laryngospasm, bronchospasm, desaturation, and severe coughing. But now it's important to remember every child who has a cold is not going to have these events perioperatively. So, your main task is to identify the patients at risk and minimize the cancellations as much as possible. So, it's very difficult to find a clean window for surgery. Like an average child will have like 6 to 7 episodes of URTI each year. So, there is not enough evidence on how long a particular elective surgery should be postponed after an episode of URTI. But the reactive airway will persist for at least 4 to 6 weeks. So it's recommended to at least postpone elective cases for 2 weeks after a severe URTI.